Good afternoon, and thank you for joining our webinar today. Just to run through our running order today, we're going to be talking about the publication of two new literature reviews that have resulted from the Autism Innovation Strategy. One of the actions in the Autism Innovation Strategy was to summarize some existing evidence related to the lives of autistic people. Two of the topics that were highlighted in the consultation for that strategy were experiences of older autistic people in relation to their health and mortality, and the experience of autistic LGBTQIA plus people, particularly in relation to their access to healthcare. The two presentations that will be given today, the first will be by Dr. Louise Lynch and Dr. Darren McCausland on the topic of autism, aging, and life expectancy. And the second will be by Ms. Ryan Biskupovich Golding, describing the healthcare experiences of autistic LGBTQIA plus people. We're going to share a link to the page on the NDA website where these are now published, along with plain English summaries, and in the case of one, along with a animation that you're going to see today explaining the results of those. We're going to ask that the question and answer session happens after both presentations are finished. Both presentations should take somewhere between 20 and 25 minutes. And when they're both complete, then we'll have an opportunity for discussion with the speakers. So please do stay for the discussion if you can. So without any further delay, I'm going to introduce our first speakers. So Dr. Louise Lynch and Dr. Darren McCausland from the Trinity Centre for Aging and the Life Course in Intellectual Disability, which is in the School of Nursing Midwifery in Trinity College, Dublin. And I'm going to pass over to Louise, who's going to start the presentation, and then Darren will join.
Thanks so much, Lorcan. I'm just going to share my presentation.
Yeah, we can see that.
Yes. Okay, perfect. So Darren and I are going to give an overview of a summary of the findings of a literature review we completed on autism, aging, and life expectancy. So this review and the findings we're presenting today will use sensitive and respectful language as much as possible. It's a very high-level view, so if you'd like more details, the full report is published on the NDA website, as Lorcan said. So the background to the research. In August 2024, the government published the Autism Innovation Strategy. Part of the strategy was for research on topics that are important to autistic people. So Action 81 of Pillar 4, which was about building capacity of the strategy, looks to improve our understanding of the key health challenges facing autistic people and their associated impact on life expectancy. And this is going to use research that informs both policy and practice around appropriate health, services and supports for autistic people. One part of this included a review of the international literature in line with the priorities of autistic people, which was led by the National Disability Authority and funded by the Department of Children, Disability and Equality. The aim of this review was to summarise the current evidence about autism, ageing and life expectancy. So what this report looks at is what we currently know about the difficulties autistic adults have when dealing with illness and death, how differences in how long autistic people live and the health conditions they may have, as well as ways to improve the health of autistic adults and help them to get better care. Just notes about the research overall. So a mixture of person-first language, for example, person with autism, and identity-first language, for example, autistic person, was used in this review. The official diagnostic category name, autism spectrum disorder, as used in international classification and the World Health Organization, was used to introduce autism. This review endeavours to use sensitive and respectful language. As a result, standard research terms have been tweaked, for example, burden of disease. So what is autism? So autism spectrum disorder, hereafter referred to as autism, is a neurodevelopmental condition whereby people present with social and communication difficulties and repetitive behavior. Autism is a lifelong developmental condition which can be diagnosed at any age, although early signs generally appear in the first 2 years of life. It relates to how a person communicates and interacts with others and how they experience the world around them. Autism exists on a spectrum, which means it affects people in different ways, at different times, and in different situations. Autism can co-occur with an intellectual disability. The current requirements for autism diagnosis under international classification state that a person's behaviour should be characterised by some essential features, which include: firstly, persistent deficits in initiating and sustaining social communication and reciprocal social interactions. Secondly, a range of restricted, repetitive, and inflexible patterns of behaviour, interests, or activities that are clearly atypical or excessive for the individual's age and socio-cultural context. And symptoms which result in significant impairment in personal, family, social, educational, occupational, or other important areas of functioning. So the aim of this literature review was to summarise the current available evidence on autism, ageing, and life expectancy, to provide insight into how to improve the health of autistic people and their access to quality healthcare. For this review, a broad definition of health to include aspects of social determinants of health and quality of life was used. A scoping review, which is a way to map existing knowledge on a subject and find out what is known and what is missing, was used. Today, we're presenting the findings in accessible language as much as possible. And again, as I said, the main report on the NDA website contains more details. So just a couple of definitions that are used in the report. So firstly, life expectancy. And this is defined as the average number of years people might expect to live according to the current age-specific mortality rates, and it reflects differences in mortality. Prevalence is the number of people with a specific characteristic, such as autism, during a given time period. While incidence is the number of new cases, for example, of autism, identified in a specific time period. So the literature research demonstrated that there was no universally accepted terminology for autism. The team looked at over 4,100 pieces of individual research, of which 115 were deemed the most suitable and useful to be included in this study. These 115 studies represented 20 individual countries and 1.2 million autistic people. The results of these studies could be grouped into 4 main topics. The first was epidemiology, which covered autism, aging, and death, and in this there were 22 studies. Then we looked at health and healthcare for adults with autism through their lives, of which there were 14 studies. Mental health of adults with autism consisted of 35 studies, and the quality of life and health for adults with autism composed 46 studies. So I'm going to talk about the first theme, which was the epidemiology of autism. So epidemiology just isn't about how common autism is. It's also about life expectancy, morbidity, and mortality. So a study from 2019 showed that the number of people around the world who are diagnosed as autistic has increased. This number went from 20 million people in 1990 to over 28 million in 2019. In 2021, globally, 1 in 127 people were on the autism spectrum. In Ireland, prevalence rates of over 1% are observed, but almost 5% of people suspect they have undiagnosed autism. Researchers found there were more autistic young adults and much fewer older autistic adults. This doesn't mean that autism goes away with age. It's because older people were less likely to be diagnosed as autistic, because autism was not as likely to be recognized when they were children compared with children today. Some studies looked at how long autistic people live. And these studies collected information from big groups of autistic people over many years. They compared this with information from big groups of people who were not autistic. When researchers compared the information about the people who died in one study, they found that autistic people died at a younger age, average about 37 years old, compared with people who were not autistic, and the average age was 82 years. However, the way these numbers were obtained may not be the most accurate. Another study found that some autistic people may have a higher risk of dying earlier than people in the general population. They found autistic people with no intellectual disability included in this study had an age of death that was 6 years less than non-autistic people. The age of death for autistic women with a co-occurring intellectual disability was 15 years less than non-autistic women. For men with intellectual disability, the age of death was 7 years less than non-autistic men. Even though it's hard to get accurate numbers, the research suggests that on average, autistic people with an intellectual disability may not live as long as autistic people without an intellectual disability. And this is especially true for women. So these results come with the health warning. We must be really careful reporting these numbers for a number of reasons. Firstly, lots of people in these studies did not die while the study was going on. Many older autistic adults were never diagnosed and are not included in these studies. It can be hard to compare numbers from different countries. Autistic people in these studies might have had more health conditions than autistic people in general. For these reasons, the reported ages of death in these studies may be lower than they really are for autistic people. So these numbers may not be completely accurate. The real life expectancy for all autistic adults is not known conclusively from these studies. Now I'm going to pass on to my colleague Darren, and he's going to talk about the second theme.
Thanks very much, Louise. So the second theme that emerged from the review was physical health and healthcare of people with autism. So the review here looked at research about autistic people's physical health. Mental health is also something that came out strongly from the review, but we'll look at that separately later. So the studies here were about which health conditions autistic people have, and also looked at how health conditions affect people's lives overall. The studies included in the review showed that autistic people were more likely to have more physical health conditions like epilepsy, gastrointestinal conditions, and Parkinson's, as well as some of the conditions associated with getting older and older age, like cancer, heart disease, and osteoporosis. So different studies included in the review showed very different results for autistic people. And this is probably because researchers use different methods, so different ways of measuring autism and different ways of measuring health. And these differences make it very difficult to get exact numbers about autism, as Louise spoke about the epidemiology. However, the research still shows that autism may have a big impact on people's health. But importantly, having autism doesn't always mean someone has poor health. The review also looked at healthcare of people with autism, and in this, we found that autistic adults often do not get the healthcare that they need. So many autistic people face difficulties when they try to get the healthcare that they need. These include feeling misunderstood by doctors or nurses, difficulty just getting services in the first place, feelings of being judged unfairly, sensory problems like being overwhelmed by noise or bright lights when in healthcare settings, communication difficulties that they encounter with healthcare professionals, simply not being enough available services. And all of these difficulties can combine to make health problems of autistic people worse over time. So to improve the healthcare access, the review showed that healthcare workers need to better understand common conditions that can happen with autism, such as anxiety and depression. Support systems need to be set up with autistic people's needs in mind, and this might include, for example, better educating healthcare workers about autism, including autistic people in decisions about healthcare, communicating in different ways that suit each person, each individual, showing more understanding and sympathy, allowing changes to minimize any sensory stress that people experience, like providing a quiet place to wait, and give support during big life changes, like moving from being a teenager into adulthood. As Louise said, autism can quite often co-occur with intellectual disability, but the review only identified 3 studies which looked at differences between autistic people who also have an intellectual disability and autistic people who do not. So in these studies found that autistic people with intellectual disability were more likely to have mental health conditions, to also have physical disabilities, and to need more healthcare and support. The third theme then was mental health. And the studies included in the review showed that mental health problems, especially depression and anxiety, may be more common in autistic people than in non-autistic people. Anxiety was something that came out as being very common among autistic people, although the numbers varied very widely between the studies included in the review, ranging from 20% right up to 86%. Depression was also a very common condition identified for autistic people, but again, the numbers varied quite widely from 16% up to 46% in different studies. The review also showed that other mental health conditions, including, for example, bipolar disorder, schizophrenia, attention deficit hyperactivity disorder, and stress may also be more common in autistic people than in the general population. Also, in the mental health findings, we found that suicidal thoughts and suicide attempts were also more common among autistic adults. The studies included showed that they may be more than twice as likely to die by suicide, and this may be related to past trauma in people's lives. Some of the studies included also found that older autistic adults may have more than one mental health condition, and that people diagnosed with autism later in life may have more mental health problems when compared to those who are diagnosed earlier in life or as children. The fourth and final theme then was quality of life and its association with health for people with autism. So some of the studies included in the review showed that autistic adults may have a lower quality of life, especially if they feel left out of social situations when compared to non-autistic people. This also affects their health and their well-being. Physical well-being problems were also made worse by lower levels of physical activity. And this was shown to happen or be made worse because of some social factors, including, for example, bullying, being excluded, difficulty people experience socializing, and feelings of loneliness. Some studies also showed that autistic people experience negative opinions about their abilities. Camouflaging as a protective strategy to fit in had both negative side effects, including feeling inadequate and being being exhausted, as well as some positive side effects in that it allowed people to interact socially and to build their resilience. People who were working, who were better educated, and who lived more independently, all of this was associated with having a better quality of life for autistic people. And having a special person to confide in and just generally better social support was also shown to improve the quality of life of autistic people. Some of the studies showed that a lack of social support can lead to lower self-esteem, and that autistic adults may also have problems finding or keeping jobs, which can affect their quality of life. The research found that autistic women, compared to other women, may feel worse overall within themselves, be more likely to have memory or thinking difficulties as they age, may have stronger menopause symptoms, including emotional and mental health problems. And one study showed that autistic women may be less socially active than autistic men. So just to wrap up on a few concluding points, I think the review that we completed showed that autism has a wide spectrum of capabilities and also includes a wide range of health outcomes and health profiles. It's important to understand that the number of people with autism in society in order so we can plan for appropriate levels of service and support. And while diagnostics and awareness have improved, there are still a lot of inconsistencies in the numbers available. And it remains the case that there are still no accurate estimates of life expectancy for autistic people for many of the reasons that Louise highlighted earlier on. The co-occurrence of intellectual disability appears to be associated with poorer health and mortality, but again, these results also need to be interpreted with some caution. In terms of healthcare, a more individualized approach to healthcare and support is needed for this population. To improve the health outcomes and quality of life for autistic people, appropriate communication, sensory accommodations, social interaction, and a more thorough understanding of autism is required. And measures to enhance social support, including peer-led support initiatives, may help to ease the effects of social isolation for autistic people. So, as Louise said earlier on, I'd really urge anyone who wants a bit more detail on the review just to have a look at the full report that's available on the NDA website. And just to wrap up, the research team would like to give their heartfelt thanks to the public and patient involvement contributors and to Gale Autism Services for their time and for the valuable insights that they provided on autism and aging. We'd also like to thank the Academic Advisory Committee for their valued inputs and the HSC as the external reviewer. Myself and Louise would like to acknowledge and thank Dr. Christian Mallon for his work on the project as research assistant and to congratulate him on recently passing his PhD Viva. We'd also like to just really acknowledge the support from the NDA team, in particular to Lorcan and Damien for their support throughout the whole project. And finally, just like as noted earlier on, the department has funded this research and the NDA has coordinated it. Responsibility for the research, including any errors or omissions, remains with the research team from Trinity College, and the views and opinions contained in the report are those of the authors and do not necessarily reflect the views or opinions of the department or the NDA. Thank you.
And thank you so much for the presentation, Louise and Darren. I can see that some questions are starting to come in through the Q&A function. So just a reminder to everyone, if you'd like to pose a question, please type it in the Q&A dialog at the bottom of the screen. So that's the question mark in the speech bubble icon. If that's not visible, you might need to select the three dots that says more, and then you'll be able to see the Q&A function. And if you type your question in there, we'll have an opportunity and I will ask some of those questions to the presenters at the end. So I'm just going to go straight ahead and introduce our next speaker. So Ryan Biskupovic Golding is a lecturer, PhD candidate, and registered mental health nurse who's based at the Catherine Macaulay School of Nursing and Midwifery in University College Cork. And Ryan is going to speak to us today about the research available about barriers, inequalities, and opportunities for a more inclusive healthcare for autistic LGBTQIA plus people. So I'll pass over to you, Ryan. Thanks.
Perfect. Thank you, Larkin. I'm just going to share my screen there, so if you could just let me know that you can see it. Uh, is that okay? Everyone able to see it?
Yeah.
There, Ryan.
Perfect. Great. Excellent. So yeah, just thanks again to the NDA for putting together this webinar and everyone that's kind of worked in the background to put it together, for giving us an opportunity to, I suppose, share these really interesting pieces of research that we've conducted. And I suppose I'm going to be, as Larkin said, talking about a specific scoping review that we conducted around LGBTQIA plus autistic people's experiences within healthcare and kind of disparities of health as well that exist within that. So just again, same disclaimer that was provided by Louise and Darren. Just the department obviously funded it. The NDA coordinated the specific research piece. But again, the responsibility for the research remains with the research team in UCC. And also we had support from the University of Galway as well. And the views and opinions contained in the report are those of the authors and don't necessarily reflect the opinions of the department or the NDA. So again, I'm not going to go and provide kind of the same level of background information that Louise and Darren did around kind of defining autism and these kind of pieces. I think Louise and Darren did a great job with that. So I'm just going to go straight into, I suppose, the actual scoping review and things that we conducted. So this is just an overview of our research team. You can see there was a kind of representation of a number of different schools within UCC. So we had the School of Nursing and Midwifery, School of Clinical Therapies. We also had School of Psychology and Education in the University of Galway, and we very much wanted to make sure that we had PPI contribution. So we had Nem and Gillian from Nora Pride Ireland, and Tara as well from Thriving Autistic, who supported us with the research. So just a massive thank you to everyone within the research team. It wouldn't have been possible without everyone. And just some acknowledgements to say thank you to the Department of Children, Disability and Equality for the coordination and the funding, and obviously for the NDA for the coordination and support around it. So then just a little note from us as well around kind of language usage and that within the specific report. So just for LGBTQIA plus language, we are using that as an inclusive kind of umbrella term for brevity, but we do obviously acknowledge and recognize the distinct experiences of gender identity and sexual orientation that exist within that and that aren't necessarily captured 100% by that particular umbrella term. Additionally, then we tried to foreground identity first language as much as possible. Again, just trying to make sure that that was reflecting, the preferences of autistic people as much as possible within that. So some studies that we identified would use clinical or person first language. We try to use autistic as a kind of identity term where possible. So just to give a little bit of, I suppose, background as to why we this particular review would be important. So, we have some research around LGBTQIA plus individuals, and we know from this that there is higher rates of mental health conditions and substance use within the LGBTQIA plus community. And we also know that there is considerable negative health experiences, things around mistrust and care avoidance. We also know then from research with autistic people that there's reports of reduced access to care, delayed diagnosis, poor outcomes, and some barriers around communication issues, sensory needs, and knowledge gaps among providers. So I suppose the rationale for this is because we know for these independent populations, but there is individuals who have that intersecting identity of being both LGBTQIA plus and autistic. And we wanted to look, I suppose, at, what healthcare experiences, what kind of health disparities exist for someone with that intersecting identity of being autistic and LGBTQIA plus. As such, we wanted to kind of frame our specific review in that idea of intersectionality, so those overlapping identities, and essentially that just is relating to how both of our identities may overlap at different stages to shape the kind of care experiences that we're having within healthcare. Additionally, we wanted to, foreground the minority stress model, specifically when we're contextualizing it in the LGBTQIA plus community. And I suppose the minority stress model specifically focuses on the unique stressors that the LGBTQIA plus community specifically was developed specifically for the LGBTQIA plus community, but that exist for individuals with that identity and how chronic stigma essentially impacts health. So the overall aim then is to look at that middle ground. So, the compounded disparities and unmet needs when someone has both of these identities, and that intersectional understanding being extremely important in order to ensure that we have equitable, accessible care for all people. So, I suppose similar to Louise and Darren, we also undertook a scoping review. And I suppose it was this is just an overview of that methodology piece, just to give you an insight. I'm not going to go into too much detail about it. Again, we have a full report if you do want to know more details on the kind of methodology that was undertaken. But these are just the steps that were involved in it. And I suppose within the methodology of it, we wanted to make sure that we had our PPI contributors foregrounded within as much of this as possible. So they were involved within our development of our eligibility criteria to decide which studies we should or shouldn't include. They were involved in our screening process where we went through the studies to identify, do they meet that predetermined eligibility criteria? The terms and words we were using to actually search within the actual databases as well. And as part of the synthesis process where we all came together to try and make sense essentially of the findings that were coming up. So just a little bit on the findings then. So we have, I suppose, as part of this project, we wanted to make everything as accessible as possible. And as part of that, we contracted an animation company to actually develop an animation. So I'm going to go through a few of the more kind of technical findings, and then I will play the animation essentially to give you an overview of the remaining findings from there. So as part of our study selection process, so this is the process where we go and find the specific studies and then see if they meet the criteria that we set out in order to be included in the review. So we started off with 1,981 studies. At the end, then we ended up with 32 studies being included for the final review. Of those 32 studies, this is just a breakdown then of what countries were represented. Just to say with this as well, if anyone is really good at maths and is counting the numbers up already, this won't equal 32. And the reason for that is two studies were multi-site. So we represented the Canada, Netherlands, the UK, and Australia were involved in those particular studies, so there's extra ones for those, and the USA as well. But you can see from this, the majority of studies were coming from the US, followed closely by the UK. We have Canada represented, Australia, Norway, Netherlands, Germany, and Ireland as well, across the studies that we actually identified for this particular review. The designs then, so there's multiple designs that can be identified, and the majority of them were qualitative, which means that they were essentially looking at people's experiences and very much representing those in a narrative form. We had some quantitative designs as well and some mixed methods designs, which were using both of the specific things. But again, especially in the context of us looking at healthcare experiences, it's not too surprising that we had a higher level of those qualitative pieces. Just to note in the populations, and I think this is important to kind of contextualize the findings, especially in this. So the majority of the studies that were identified were actually the populations included with them were trans and gender diverse autistic adults. So they were identified across 14 studies. They were the primary population. Across 7 of the studies then, it was trans and gender diverse autistic youth. There was 6 studies then that looked more broadly at LGBTQIA plus autistic people. And then there was 5 studies that weren't necessarily looking at LGBTQIA plus people. However, there was people who identified as LGBTQIA plus autistic people, and we were able to take the data specific for those individuals from that specific study. So just to contextualize that the trans and gender diverse community are more represented in this sample when we're talking about the LGBTQIA plus community as an overall for that. So just some of the healthcare focus then across the 32 studies. So I suppose the highest prevalence was specialists and tertiary services, and this is basically studies that covered things around kind of experiences of gender dysphoria, pieces around kind of service access, healthcare needs. Our system policy population level then was represented across 9, and this covered things like mental health, general health, service access, health outcomes, specifically around kind of system and policy level. Non-service community level was next then with 7 studies, and that generally looked at healthcare experiences, intersectionality, challenges, and resilience. So those are the kind of themes that were coming up across those. And then primary care and community mental health were present then across 4 studies. So again, general and mental health services navigating health and health outcomes for that piece. I'm not going to go into too much detail about the quality appraisal because it can get a little bit too technical around that, but just to say that we did perform quality appraisal on the different studies. We used a mixed methods appraisal tool for the empirical studies, so the ones that would have been peer reviewed and published within different kind of journals. And these are some of the areas, I suppose, that we were looking at when we were looking at concerns around specific quality. So whether, there was unclear measurement validity, whether, did the sample of people included in this actual study represent the sample that the specific study we're looking for? And these kind of pieces. Again, this is in much more detail in the report. So you can get a lot more detail about the different outcomes for that in that specific report. Then again, we had one specific record that was a report, and as such, we used the AACODS checklist for that. And again, this is just an overview of some of the things that we were looking for in the context of making sure or kind of assessing or appraising the quality of that particular piece. Just to note as well, with the tools that we used, we weren't aiming to score quality in the context of seeing if something is high, medium, or low quality. It wasn't about that. And there was no studies excluded at any point on the basis of quality for this. We wanted to make sure as many studies as possible were included so we could get a picture, but we did, as part of that, produce a kind of a narrative identifying the concerns that we maybe had around the kind of quality within different studies. So I'm going to start the animation here now. So it's about 8 minutes long. So I will stop talking for a while and I will hand over to the animation, and then we'll go into a little bit around kind of recommendations and some kind of just to highlight some of the limitations as well with the review. So I'll start that there now. Just let me know if the sound isn't working as well.
Towards inclusive health. Health experiences and disparities of LGBTQIA+ autistic people. 1. Welcome and purpose. Hello and welcome. This animation is about a research project that looks at the healthcare experiences of people who are both LGBTQIA+ and autistic. These are identities that are meaningful, important, and deeply personal. We want to understand these experiences so healthcare can be more respectful, inclusive, and effective. Everyone deserves to feel safe, heard, and supported when accessing care. 2. Respecting identity-first language. For some people, being autistic is also an important part of their identity and how they understand themselves and the world. For others, it may feel more like a clinical description than a personal identity. In this project, we use identity-first language, like autistic people. It recognizes being autistic as part of someone's identity, culture, and way of experiencing the world. Language is not just words. It reflects how we see and respect each other. What matters most is listening to people and using the terms that they choose for themselves. 3. Overlapping experiences. Research shows that LGBTQIA+ people and autistic people often face unfair treatment in healthcare. They may not receive the same respect, understanding, or support as others. But very little research has looked at people who are both LGBTQIA+ and autistic. This means their unique experiences and needs are often overlooked. This project helps to bring those experiences into view so that they can be properly recognized and addressed. 4. Research and lived experience. We reviewed many sources, research studies, reports, and community-led work. We included studies that used personal stories, interviews, surveys, and mixed approaches. We also made sure to include research and perspectives led by LGBTQIA+ autistic people wherever possible. Without these voices, understanding remains incomplete. Our goal was to look for patterns about what gets in the way of accessing care, what helps people to feel supported, and what needs to change. Put together, this helps us to see the bigger picture. 5. Barriers to care. We found that LGBTQIA+ autistic people often face many barriers in healthcare. These include healthcare providers who don't understand or recognize their identities, sensory environments that are loud, bright, or overwhelming, complicated systems and long waiting lists, and financial challenges that make care harder to access. These challenges are often even greater for transgender and non-binary autistic people. These barriers can add up and make healthcare feel exhausting, confusing, or unsafe. 6. Supportive care makes a difference. We also found that some things help people to have better experiences and outcomes. People feel more supported when healthcare providers listen, learn, and respect identities. Communication is clear and flexible. Spaces are calm and sensory friendly, and when community or peer support is available. However, many of these helpful supports are not built into the system. Often, people have to create their own solutions or find help outside formal healthcare. This shows that change is needed at the system level, not just the individual level. 7. Inequalities are system-made. Because of these barriers, LGBTQIA+ autistic people are more likely to experience delays in autism assessments, delays or refusals for gender-affirming care, and mental health needs that are not properly supported. These problems are not caused by who people are. They are caused by systems that were not designed with them in mind. Acknowledging this is the first step towards meaningful change. 8. Change is possible. To improve healthcare, we recommend training staff to understand autistic and LGBTQIA+ identities and how they can overlap, making healthcare spaces calmer, more flexible and sensory friendly, reducing waiting times and financial barriers, collecting better data so services know where improvements are needed, and most importantly, involving LGBTQIA+ autistic people in designing and evaluating services. When services are shaped by the people who use them, they become more effective, respectful, and trustworthy. 9. Everyone deserves respectful care. In summary, LGBTQIA autistic people are not facing challenges because of who they are. They are facing challenges because healthcare systems have not yet adapted to include them. but systems can change. With respect, inclusion, and collaboration, we can build healthcare that is welcoming, accessible, and affirming for all. Thank you for watching and for being part of this change. Information for this animation was taken from the published report, Towards Inclusive Health, Health Experiences and Disparities of LGBTQIA+ Autistic People, a scoping review. Biskupovich Golding, R.
I'll stop that there because it just goes into some of the additional kind of pieces and disclaimers. Thanks. So that's just a very kind of brief overview of kind of some of the findings and these kind of pieces. And again, if you have questions, please feel free to pop them in. And obviously the report and things are available as well, but we're just going to have a look at some of the recommendations now based on the actual piece of research that we conducted. So you'll see here we kind of identified 7 specific recommendations, I suppose, and we kind of mapped them to the individual systemic level. You'll see from the video as well and from the animation that these are kind of highlighted within it, but just to talk a little bit more on them. So I suppose enhancing competence is a major part of this. A lot of experiences of feeling misunderstood and feeling like identities weren't validated or properly taken into account during a lot of experiences within healthcare. And as such, there is a need, I suppose, to train providers on diversity and inclusion, but also training providers around the pieces of how these identities are intersecting. And what does that mean? What does that look like? And this is something that both the LGBTQIA+ community and the autistic community, without the intersecting overlap, experience anyway. So it is something that is compounded by the fact of having both of those intersecting identities, 2 identities that aren't necessarily fully understood in the healthcare setting. Another piece was kind of about adapting service environments. Again, making sure spaces are accessible as possible, making sure that they are created with, sensory sensitivities in mind, and making sure people have spaces should they need them within healthcare settings. Improving data collection as well. So we identified that there wasn't a whole pile of collecting relevant data. There was situations, experiences reported by participants where, while having an intersecting identity, it wasn't something that was communicated effectively or collected effectively when in healthcare settings. And without that, we can't then, on a national level, plan for improvements if we don't know the actual statistics and these kind of pieces. So implementing policy approaches then, so very much integrating intersectional considerations into national policies, into local policies within healthcare settings, and ensuring as well that when these are being integrated, that there is co-production included in that throughout, so that members of the autistic community are present and given, power in how to in what ways these policies are developed. Promoting research, again, making sure that like we have information now around kind of experiences, disparities, but I suppose we weren't able to find any research around interventions specifically for LGBTQIA+ autistic people within the context of the search that we conducted. So that is something, and that is an area that maybe we need to promote research in around ensuring that there is intervention related studies and interventions being trialed to see what is actually working for LGBTQIA+ autistic people. Embed lived experience. I know we hear about this a lot, but it is so vital for any sort of service design, evaluation, or delivery. Without the people who are receiving care involved in the decision and the design process, we have no idea if it's going to actually necessarily be as impactful as we want it to be. So making sure that we have people with that lived experience present is really, really important. And then at the kind of highest systemic level, we need to look at kind of addressing barriers. So again, it's about that piece around equitable access to care and making sure that those who need additional resources are provided with those additional resources in order to, reduce wait times, ensure that experiences are positive, and these kind of pieces. So that's another kind of recommendation that we had in relation to that. Just to note some limitations, and this is just in the context of I suppose some of the studies that were identified. So you saw that the specific studies came from, a variety of different countries, and they were represented. However, when we look at a more deep level at those countries, they tended to be high income, predominantly white countries. So because of that, it will limit the, I suppose, applicability of the findings to countries who are kind of lower income, and then any countries that have a more racially diverse LGBTQIA plus autistic population. So that is something that needs to be kept in mind when interpreting these pieces. A narrow population focus as well, as I said earlier, the trans and gender diverse community were specifically highlighted within this particular review, and that's because the studies that were available and identified predominantly focused on the LGBTQI or the trans and gender diverse population. So it may not be able to fully reflect the experiences of lesbian, gay, and bisexual people, or intersex individuals as well. So that is again something just to bear in mind when interpreting these kind of findings. And then while I suppose we didn't have a limit on any of the studies that they had to be in an English language, the studies that we identified were only available. There was only English language studies. So we wanted to just highlight that as something that might have potentially excluded on some level non-English research. And again, this could be obviously because we were, using English language to do the searching and these kind of pieces, but just to bear that in mind as well for that. So just to a little nod towards the outputs. So the full report, the plain language summary, and the animation. So those are the three different kind of pieces that we created out of this project, and they're available on the NDA website. This particular QR code is just again, you can scan it; it'll bring you to that specific NDA website, and that is essentially where those will be available. So just again to say a massive thank you to the NDA, to Lorcan, to Bevan, to Damien as well for all the support they showed all of us throughout the whole process. It was a pleasure working with the NDA, and just a massive, huge thank you to our PPI contributors as well, because without them, I don't know if this would be necessarily as meaningful as it turned out to be. And just to thank all of the rest of the team as well in UCC and the University of Galway for all their support with it. So thank you. That's me, and I welcome any questions.
Brilliant. Thank you so much, Ryan, for an excellent presentation, and thanks to Louise and Darren for yours. So I'm just going to give a reminder yet again to submit your questions in the Q&A. While people are submitting their questions, I'll also say a reminder of what Ryan's just said is that the reports are available at nda.ie/publications. Ryan's report is the first link on that page, and Louise and Darren's is the second. And on each of these pages, you'll see the reports themselves alongside a plain English summary of the main findings of each of the reports. And we encourage you to have a look at those reports and to share them with anyone that you think might be interested. I just want to go through a couple of thank yous before we go to the Q&A section as well. So we'd like to thank first and foremost all of the research participants and public involvement contributors who took part in these reviews, but also those who took part in the primary research that was summarized by these research projects, because without those participants, that research wouldn't be possible and this webinar wouldn't be happening. We'd like to thank also the research teams at Trinity College Dublin and University College Cork. We'd like to acknowledge the Department of Children, Disability and Equality for commissioning these reviews, and everyone who is involved in the creation of the Autism Innovation Strategy. I'd like to thank Leila and Amanda for their ISL interpretation today, and Judith for live captioning the event, and also to Ray from Staunton Media, who's run the technical side of the webinar. I'd like to thank some of my NDA colleagues for their support, particularly Bevan Murphy and Tanya Hosanian. Finally, I'd like to acknowledge a former member of staff mentioned a number of times already, Dr. Damien Hazlett, who was instrumental in coordinating the earlier stages of this research project. So now I will go to some questions. So just to start us off, we have a couple of specific questions for Louise and Darren. So one of those questions is in your section on prevalence and incidence, can you comment on what the latest evidence is about how many autistic people also have an intellectual disability?
Okay, so we didn't specifically look at this in the review, but what the evidence says is anywhere from 30 to up to 50%. So roundabout. There are typically more females than males who present with an intellectual disability.
Thank you. And then another question that was posed is that given the belief that autism was until recently considered to be more present in males, is there any evidence in the literature that you reviewed that's reflecting a move towards a greater gender balance in diagnosis in recent years?
I'm not sure if there's any evidence of that in the review. Louise, do you recall anything?
There wasn't in the review, not that we came up with, but what did come up was that girls are, because of, it looks like girls are better at camouflaging when they're younger, so they're typically not diagnosed until later. But that wasn't part of the review. No,
All right, thanks.
sorry.
That's all right. Ryan, do you have anything to add on that? Or is there anything? No, okay, it's fine. So another question that's come in was about the point that you raised in relation to people who were diagnosed as autistic later in life, having some evidence that they were having more mental health difficulties. Was there anything that you could comment on from that evidence that gives any indication as to why that was the case?
Yeah, well, I suppose from the evidence that we have, and again, it wasn't one of our direct questions, but there certainly was some evidence that people who are diagnosed later in life do experience more mental health problems. Um, I suppose some of the reasons underpinning that might relate to, I suppose, maybe the stress of as we suggested earlier on, the camouflaging side of things. People may the wearing of that, also the unaddressed health problems that may go along with autism that haven't been addressed as well earlier in life, where people just get on with things and muddle through as best they can without perhaps addressing the health problems that might be associated with that.
There was also I think that was in the report as well, Darren, wasn't it? That if there was an earlier diagnosis led to earlier interventions, which so there was more targeted therapies to improve like social communication. And the earlier people were diagnosed, the earlier the interventions could start, and this resulted in improved quality of life. And this was one of our PPI contributors. He was diagnosed in his 50s, and he said when he was diagnosed, it was like a light bulb went off. You know, it explained experience he had in his childhood, in his education, and even in work situations. So he got clarity on, you know, why his life was the way it was, and he got a greater understanding after his diagnosis.
Thanks. So there's just a clarification question that came in there for Darren. It says, when you refer to mental health problems, do you mean mental illness?
Yeah, it's the conditions that were identified in the report included anxiety, depression, um, the other ones that I don't recall off the top of my head. But yeah, the evidence that was there, yeah, around those specific diagnoses.
Yeah, so I think the question is just that the review is looking on the overlap with diagnosable mental health conditions as opposed to potentially subclinical threshold difficulties in mental health that might not warrant diagnosis. There's a question that perhaps both can answer, which was a request to say a little bit more about the extent to which autistic co-researchers or autistic contributors were involved in your projects. So Ryan, I know you mentioned in your talk, but if you'd like to elaborate a little bit about the process of co-production in your work.
Yeah, absolutely. So I suppose as part of the tendering process, we reached out to Nora Pride Ireland, and we also reached out to Thriving Autistic, and they kind of had nominated individuals. So Nem, Gillian, and Tara were our nominated people. So they were involved in all of our meetings essentially throughout the process. They were involved in the process of identifying the key terms around kind of how we were going to go, the words we were using to actually identify the studies. They were involved in the kind of conduct of it as well, in the sense of, being involved in screening, being involved in the searching process, those kind of pieces. And then they were also involved in the pieces around the writing up of the findings and the interpretation of the findings. They supported us in the kind of development of the background context setting piece. And again, that we had regular meetings with them. And kind of, I suppose we just to speak on the kind of, I suppose, the format of the PPI piece, we, used whatever platforms were most suitable for our PPI contributors. We identified that at the start and moved forward with that piece. And then just to highlight that we did compensate the PPI contributors for their time as well, because that is an important aspect of the process as well, I believe, in the context of remunerating people for their expertise.
Thanks, Ryan. The same question for Louise.
Okay, we had PPI contributors, but unfortunately they weren't as involved as Ryan's team. We consulted our PPI contributors mid-project to validate what our findings were and what we had found and what we had seen, just to make sure we were on the right track. We spoke to people who had autism and then people who had a co-occurring intellectual disability. One of the people we spoke to was actually she had an intellectual disability and was nonverbal. So her experiences were related to us through her carer, but everybody else we spoke to directly.
Perfect, thanks. So there's another question from the related to the first presentation, which is saying while it's interesting to know the number of people who may be autistic, it doesn't necessarily help us to plan services, as there isn't a direct relationship between a diagnosis and the personalized services that people may need. The question is, would Louise and Darren agree that more emphasis should be placed on needs-based approaches rather than diagnostic-led approaches in services?
Well, I don't think it necessarily has to be one or the other. I think we probably need both. I think we certainly need to improve the data, the evidence. One of the key findings from our review was the real need to improve the data at a high level, and we also saw the need to improve individualized care and healthcare as well. So I wouldn't necessarily think it has to be one or the other. I think uh, we certainly need more evidence for policymakers, because we really need to be focused on evidence-informed policy. So without that evidence, it's harder to make a case for any to plan for services and to make a case for improved services.
Yeah, so I think the conclusion you're saying is that understanding the prevalence of how many people are autistic is important, but it's not the whole picture. You need more
Yeah,
information.
I think it's a starting point. Yeah,
Okay,
yeah,
yeah,
and it's difficult to move forward without having that starting point, I think.
yeah, that's helpful. So a question for either team was in relation to conclusions are often drawn about the need for training for people who are supporting autistic people. Does anyone have any particular training that they would recommend to anyone on this call who's a practitioner?
I'm not aware of any specific kind of LGBT and autistic training specifically, but I know LGBT Ireland provide a lot of um, training that is available for kind of working in healthcare settings with LGBTQIA plus people. And I know obviously Tenny does some work as well, the Transgender Equality Network of Ireland, specifically for trans people. And there is also the Professional Association for Trans Health Ireland are developing some education materials as well around working with trans people specifically in primary care. Um, Anyone specifically in Cork, which is where I am, the Gay Project do a lot of training as well for kind of working with LGBTQIA plus people and making sure spaces are more inclusive. So again, there might be some pieces within that because I think they will take more of a higher level focus of like inclusivity, safety pieces that could be applied to that intersecting piece of being LGBTQIA plus and autistic as well. So that might be a good place to start from my perspective anyway.
Okay, from our perspective, I know as I am run workshops and the National Intellectual Disability Studies run training courses for to help with yeah, sorry. The National Institute of Intellectual Disability Studies, yeah, that's what it's called. Run courses as well.
Great, thanks. And I might use Chair's prerogative if that's okay, just to highlight that the NDA have actually published a number of relevant resources on this recently. So one is guidance for public sector bodies who are commissioning disability equality training. So that might be worth checking out on nda.ie/news. There's a link to that. And also there's an e-learning module about disability rights that could be of use as well. Another question for Ryan came in about whether your review specifically identified findings of autistic intersex people or whether that's a theme that came up.
Yeah, so we looked, I suppose, across the demographics, and I would have presented those in the context of the TGD people being more kind of represented within the findings. There was no studies that focused specifically on the intersex population that we identified, and the more broad kind of LGBTQIA plus people, we didn't go into depth, I suppose, of dissecting the specific identities within that. So we wouldn't have kind of identified or taken out if there was specific things related to the intersex community, particularly. But from memory, I don't think there was a high representation of the intersex community across the research anyway, which isn't something that is kind of surprising in the context of knowing about that particular research landscape that sometimes the intersex community aren't focused on enough. So there is definitely some pieces around that intersection between being autistic and being intersex as well that needs to be explored further.
Again, another question for you, Ryan, if that's all right. So this question is, you mentioned that there was more trans and gender diverse autistic people in the studies that you reviewed.
Mhm.
Um, can you comment on, is that because they presented in higher numbers within the autistic community or because there was more studies focusing on this particular group?
Yeah. So it was mainly because there was more studies focusing on this specific population, the trans and gender diverse population. But I suppose from wider research, there has been kind of large scale population research conducted, and it was kind of identified that trans and gender diverse individuals are between 3 and 6 times more likely to also be autistic in comparison to their cisgender peers. So it would kind of make sense. And I know there has been, my own particular research areas around trans and gender diverse individuals. And, I know that there has been a push around kind of research recently in the last number of years around kind of trans and gender diverse autistic experiences. So that would be the reason that I would kind of pose for that.
Perfect. We've also just had someone highlight to us that the HSE have delivered an autism awareness training that's available on HSE Land website. And this particular training is co-developed and delivered by autistic people. So for anyone who has access to HSE Land, that might be also worth, and particularly looking for training in the health and social care context, that might be a good source for people to refer to. Um, there was a question in relation to Louise and Darren's presentation about whether there's any evidence from the literature that you reviewed that associated aging, quicker aging with autistic people, so autistic people showing signs of aging sooner.
Um, from the review, I don't think there anything specific came up, but we know that for people with intellectual disabilities, certainly do across different health conditions, age-related health conditions do display those earlier. So it may well be there's some overlap there for the proportion of people with autism who have intellectual disability, but we don't really know from the review or to say for sure whether it applies to autistic people in general. So I think there's a bit more research needed on that one.
Yeah.
Perfect. And there was a question that came through in relation to if a person, for Ryan's presentation, if a person had a diagnosis of both autism and ADHD and were LGBTQIA+, would they have been included in these studies? Or did the studies sometimes only look at people with a single diagnosis?
Yeah, so I suppose with it, we were for the purpose of this, we were specifically looking at individuals who had that intersecting identity of being autistic and LGBTQIA plus. So it wasn't that if someone had an additional diagnosis of being ADHD, they weren't necessarily excluded, but we were focusing specifically on the autistic elements of it within that specific study. So they would have been included provided that that study we could extract specific data related to the autistic experience as opposed to the ADHD experience. That makes sense.
Yeah, thank you. And then just a clarification question for the non-speaking person who was included, did they take part using augmentative and alternative communication? And if so, can you explain how that worked?
No, they didn't. Their carer talked about their experiences and health as opposed to, so they didn't represent how they were feeling. The carer talked about, yeah, their ex life experiences and from their perspective and their health. That was it. There was no augmented communication.
All right, thanks. And I might just pose a final question to both, which has come through in relation to whether there was any evidence in either of the reviews about the impact of diagnostic overshadowing. So people who aren't familiar with that term, it's when something is ascribed to somebody's diagnosis, but may result in something else being missed. So where people might think something is associated with being autistic and therefore they miss something else that's of relevant to their care. Was there any evidence, first of all, in Ryan, did this come up at all in your research?
It didn't. I'm trying to think about it in the context of the diagnostic overshadowing. I don't think there was anything specific around things being missed. There was the pieces around more like say autistic identities taking the foreground in comparison to trans and gender diverse identities and vice versa. So in situations not communicating that someone had that intersecting identity was something that came up for some of the participants of the studies, but also not being able to, or autistic identities being perceived as something that prevented access to care for trans and gender diverse people specifically. So identifying, a perception that participants felt that providers were using an autistic identity to deny them access to gender affirming care in that capacity. So that's the only kind of real area that kind of came up around that kind of piece, I suppose, within the context of this particular study. Yeah.
There was no evidence that we saw in our review of diagnostic overshadowing.
Okay, perfect. Thank you so much for to our presenters today for the presentations. As I've mentioned already, the publications are now on the NDA website. So if you go to nda.ie/publications, you can access both. And also everyone who has registered for today's webinar, irrespective of whether they could attend or not, will receive an email next week with a link to the publications and also a link to the recording of the webinar. So please do pass on the link to either or both to anyone who you think might be interested. And thanks once again to all of our contributors today.